Assalamu alaikum, everyone. I hope you're all doing great. My name is Alkatmah. I'm a fourth year medical student, and I'm honored to be starting the MSI crash course with part one on bones and joint disorders. Um, with that being said, since this is a recorded session, I have here my phone number and my email in case you have any questions later on, like that you have throughout the session or at the end. Please do not hesitate to send me a message or an email. I'm more than welcome to help in any way possible. All right. With that being said, I also want to say that this crash course is really inclusive. And when I say really, like it's really, really inclusive. So whether it is a first study or like a revision or anything, I hope inshallah, it serves its function really well. And yeah. With that being said, I will start with the content. So we'll be covering 10 lectures from MSI. The first two are Biochem. The second four are Pathology, and then the third three are clinical. The last one is genetics. All right. We'll be starting with the first Biochem lecture on medications and aberrations in the nucleotide pathway. Before we start with the pathway itself, let's go to the beginnings and the basics of it all. So nucleotide. We all know this from biochem. That's why in those two biochem lectures, I'll be like zooming in just very quickly through like everything just to like have a brief like just so we can remember everything briefly, but inshallah everything will be clear. All right, so nucleotide, it's basically a nitrogenous base with and a pentose monosaccharide and a phosphate group. All right, it's formed. I have a liver picture here because it's usually synthesized in the liver, also sometimes in the brain. But what are nucleotides? They are classified into two groups, purines and pyrimidines. Okay, we also know this from all. Purines are adenine, guanine. Pyrimidines are cytosine, uracil, and thymine. A way we can memorize purines is by the mnemonic pure as gold. So purine. A is for adenine. G is for guanine. All right. The nucleotide roles, which is what makes everything makes sense. All right. Why do we need to know the nucleotides? All right. So first of all, they're important because they're precursors for DNA, I'm sorry, and RNA of our cells. Also, they're involved in energy metabolism, such as ATP, GTP, CTP, and UTP. Third, it is the structure of many coenzymes. And last, it activates the sugars in the biosynthetic pathways. All right. So with that, we'll be starting with the nucleotide pathway itself. I'm not gonna dig deep into the nucleotide pathway. I'm just going to be mentioning the important things and what we need to know regarding this lecture. All right. So the first purine derivative from the nucleotide pathway is the inosine monophosphate, which is IMP. It's seen here. All right. The IMP forms AMP and GMP, which are two nucleotides that we just talked about. And they have negative feedback inhibition, and so it's easy to know that AMP will be inhibited by AMP, GMP will be inhibited by GMP. The AMP needs GTP to be synthesized, and the GMP needs ATP to be synthesized. All right. Now, as the pathway itself, we start with the ribose 5-phosphate. The first rate limiting step and enzyme that is very important to know is the PRPP synthetase. All right. This will give us the PRPP from its name. Next on, we have the other important enzyme that we need to know, which is glutamine PRPP amidotransferase. All right, this catalyzes the first committed step in purine synthesis, which gives us the 5-phosphoribosylamine. Now, then there'll be 9 steps, which we do not care about here right now. But later on, it will give us the IMP that we talked about, which is the inosine monophosphate. All right. This will like this whole nucleotide pathway, when it gives us the AMP and GMP, we also need the reverse of it, which is the catabolism. All right. So when we get the AMP and the GMP, in order to recycle, we go through a process called nucleotide catabolism, so we can have other products made from it. All right. What are these products? It's mainly hypoxanthine and so we start with GMP, then GMP becomes guanine, AMP becomes IMP, and IMP becomes hypoxanthine. Both the guanine and the hypoxanthine give xanthine and later on uric acid. I mentioned here some of the enzymes that we need to know. They're not super high yield, but it's good to know. So when mentioning the nucleotide catabolism, we need to know that recycling or salvage is really important. Why? It's needed to maintain the purine pool. All right. How do we recycle those hypoxanthine and the guanine? By adding them to PRPP, all right, which we mentioned before. Which enzyme do we need for this? Hypoxanthine, guanine, phosphoribosyl transferase. This is a very, very important enzyme that will in a bit, but for now, just know those two like equations here, hypoxanthine and guanine, that give us IMP and GMP by HGPRT. All right. Why is this enzyme super, super, super important? It's because if this enzyme was not there, we would have some diseases. First being the Lesch-Nyhan syndrome, which is an X-linked recessive disorder caused by this enzyme deficiency. It will lead, of course, if we do not have this enzyme here to do those stuff, we will have excess of these right here, hypoxanthine, xanthine, and uric acid. All right. This excess uric acid will cause gout and severe neurological symptoms because it deposits in the brain. Now, those affected patients show self-mutilation behaviors. Why? Because, as we said, of the retardation that they have. So what happens is that they start biting off their lips and fingers, which is super, super characteristic of this syndrome. That now, an easy way to remember the clinical image of is by the enzyme that is deficient in itself, which is HGPRT. Here I have quick nice mnemonic for that. So H stands for hyperuricemia, which we mentioned here. G is for gout. P is for pissed off because of their neurological symptoms. R retardation, and T hypotonia, which is decrease in muscle tone because of the neurological symptoms. Here are some pictures I have added throughout the whole crash course. You'll notice that I've added as many pictures that I can, because one thing I know about exams, when you know like pictures, sometimes it gives you an easy mark. So know and try to memorize as many pictures as you can, because this will only benefit you and it will help you remember if you were to forget. All right. So here's the lip biting and the nail biting and the mental retardation and everything. All right. Now, other than Lesch-Nyhan syndrome, we have another disease, which is gout. Gout is as we mentioned from a little bit, the uric acid deposition. All right. Now, it's not only uric acid. I'll mention here that it's also crystal plus uric acid deposition that give us gout. So uric acid by itself does not give gout. It's also the crystal deposition, which I've added a picture of here. Just know in case, I think it might come in OSP or something. Again, one thing about pictures, they can come in OSPs and SAQs and MCQs. So knowing them really does benefit, inshallah. This picture here shows the different places where like gout can come from. So we have endogenous purine synthesis, which is inside our body, that we just mentioned here. And we have the dietary purines, which we later talk about which like food in specific causes purine nucleotides. Okay, so basically those purine nucleotides will deposit along with the crystals to form the gout, and we do have renal excretion of uric acid, but again, gout does have two types, primary and secondary. The primary is just the idiopathic hyperuricemia that we talked about all this time. The secondary is if this renal function is diminished, so there is no excretion of the uric acid as normally it should be. All right. Now, gout can like have those things that I've mentioned here. There can be hyperuricemia in most cases. There can be recurrent attacks of acute arthritis. There can be uric acid nephrolithiasis, renal disease, and aggregates of monosodium urate crystals. These are the exact crystals that are here in the picture. All right. The gout has stages, 4 stages actually, and it starts with being asymptomatic. Asymptomatic hyperuricemia has elevated serum urate but no clear manifestations. Later on, it comes an acute flare with acute inflammation, and thirdly, there is intervals between those acute flares. Lastly, it's advanced and it's chronic and long-term with complications. Now, the higher the stage, the more uncontrolled the hyperuricemia is. Here I've added the risk factors of gout in pictures, hope it sticks. So firstly, here's a king. You would ask why is that? So first of all, it's because male, so this disease shows more in males. Second of all, he has high BMI, as you can see, and high like waist what is it called? Like the diameter. All right. And thirdly, he's a king because this disease is known to be the disease of kings. Why? It's because kings historically kings used to eat so much meat because they were super rich, of course, and meat was the food of the rich along with alcohol, as I add here, and they wouldn't be active as much. So having this purine intake with no activity leads to gout. All right, and of course the increase in age. So typically above 40 years old, the lower temperature and low pH environment, like in the body, causes gout. Excess fructose, as I've added here, and some drugs such as cyclosporin, diuretics, and low-dose aspirin. It's specifically low-dose aspirin because high-dose aspirin actually causes the opposite. So yeah, these are some risk factors. Just know them just in case. And here's the treatment. Now, for the treatment, I'm not going to go in depth because there will be a crash course, MSI crash course for all pharma. So you'll find out that throughout this whole crash course, I'm not going to be really focusing on treatments and pharma as much because there will be a separate crash course for that. But basically, like for gout is there's a different treatment for the acute, and here they are. It's first line is NSAIDs, but mainly we do use colchicine. The prophylaxis drugs are colchicine and NSAIDs again. They are urate lowering therapies and adjuvant therapies. All right. The most important being lifestyle modification, of course, because of the foods that we just mentioned. So it will be lowering these foods and having other foods. Okay. Here is a very quick pop quiz question since we've finished. And since this is recorded, I'm just gonna give like a quick second so you guys can answer this. I do urge you to pause the YouTube video and answer it on your own. But yeah, so a 2-year-old boy presents with recurrent episodes of self-mutilation, biting his lips and fingers. He also has hyperuricemia, developmental delay, which enzyme deficiency best explains this condition. We talk about this, it's B, hypoxanthine guanine phosphorotransferase, or HGPT, right? Yes. Another question. A patient presents with acute monoarticular arthritis and renal complications. Joint aspiration reveals needle-shaped monosodium urate crystals. which of the following is most condition? Here's a minute, and then it is hyperuricemia. All right. With this, we're done with the first lecture. I hope it's clear. Again, if not, please do let me know by sending a message or an email later on. All right, for the second lecture, it is collagen biosynthesis and collagenopathies. All right. First, six collagen. We all know collagen is different types in the body, in different places in the body. So in the hair, in the nails, in the cartilage, in the bone, in the skin, and connective tissue. It actually makes most of the connective tissue. And as we age, the collagen decreases in our skin. This is what wrinkles. All right. There are different types of collagen. There's 1, 2, 3, 4. Now each is found in different places. So the first one, most common, it's 90%, is found in bone, skin, tendon. The decrease of type 1 collagen production shows in osteogenesis imperfecta type 1, which we'll later on discuss. As for type 2, the cartilage, it's found in cartilage, vitreous body, pulposus. This is mostly in the vertebrae. There is no need to know the disease of it. It's not mentioned in our lectures. Type 3 in the reticulum, skin, blood vessels, uterus, fetal tissue, granulation tissue. And this is the deficiency of this shows in Ehlers syndrome. And lastly, type 4 is in the basement membrane, basal lamina and lens. The disease of it shows in Alport syndrome and Goodpasture syndrome. All right. All right. So collagen synthesis. I'm pretty sure we also have talked about this before in one lecture. So I'm again not gonna go into depths of it. But basically, there are 4 steps that happen intracellularly and steps that happen extracellularly. Okay, here's a picture to make it stick better. But basically, we start with translation on ribosome of the pre-pro collagen and hydroxylation of the pro and LYS. And all this happens in the endoplasmic reticulum, intracellularly. Then this it will be released from the ribosome and it will be glycosylated and formed as a triple helix. Okay, this is now the pro collagen. There is no pre. And cytosol. Now, the other 4 steps that happen extracellularly when it gets secreted from the cell, first of all, there is the cleavage of the amino and carboxyl terminal propeptides, then the assembly of the collagen fibers in the quarters staggered alignment, as you can see here, and then oxidative deamination of the amino groups and formation of the crosslinks, as we can see here. All right, not much field, but good to know because if you want to know the pathology of something, you have to know how it looks normally first. All right. So collagenopathies arise from genetic defects or from nutritional deficiencies. All right. There are a couple of genes named here with their diseases. Now, as we go through this crash course, we'll be covering them, like the ones that are important. But basically, the COL1A12 are for osteogenesis imperfecta, osteoporosis, and Ehlers-Danlos. The for osteoarthritis, and so and so. I believe those are not very important. Lysyl hydroxylase is important for Menkes disease. We'll be covering it too. All right. What is the best friend of oxygen? It is the vitamin C. Why is that? Because with like vitamin C, without vitamin C, the enzymes prolyl and lysyl hydroxylase do not work. And why do we need them? We need them because they convert the hydroxyproline and hydroxylysine from proline and hydroxyproline and hydroxylysine. All right, it uses oxygen, iron, and vitamin C, and that's why they're best friends. And if that best friend leaves, what happens? Again, disease. So scurvy is the disease of the deficiency of prolyl and It shows mostly in those that do not get enough vitamin sun from the food. That's why I've added here a sun and an orange. But basically, it was known to be a disease of the sailors. Why? Because sailors would be gone for months, and they wouldn't eat like just food that had vitamin C. That's why they would come back having scurvy. Scurvy is basically bruises and bleeding in different places, such as the gums, teeth gums, and the legs, because of subcutaneous extravasation of blood due to capillary fragility. All right, this is for scurvy. Another syndrome is Ehlers-Danlos syndrome. Now, this is also a lack of lysyl hydroxylase, but not only that, it's also a lack of peptidase or mutations in collagen types 1, 3, and 5. So it can be caused by 3 deficiencies. All right. The collagen is degraded to high levels in intracellular compartments, and it's mainly collagen type 3 that is important to arteries. So that's we have a deficiency of collagen type 3 here. It causes potential lethal vascular problems. Okay, here are some pictures. So it shows our ability in joints, as you can see here, and hyper elasticity of skin, as shown here. All right. There's a specific type of Ehlers-Danlos syndrome, which is the type 4. It's usually referred as the vascular type. It's caused by mutations COL3A1, as we just mentioned, and it causes to physical findings found here. Face of Madon is this characteristic finding, and acromegalia, which is the premature aging of skin, as well as the blood vessels showing like really visible. All right, really visibly. Another degenesis imperfecta. It is known as the brittle bone syndrome, and it's a group of disorders that are inherited where bones break and bend easily. All right. There is also poor wound healing and twisted or curved spine, which is known as kyphosis. Pictures here. So here are the bones bending and twisting, and this is a blue sclera. Why is there a blue sclera here? It's because of the thinning of the layers of the eyes due to deficiency of collagen. So it shows as a blue sclera. It's not really documented much in osteogenesis imperfecta cases. However, it's good to know just in case picture shows up in an exam. All right. Now, there's also a more specific type of this disease known as osteogenesis imperfecta congenita. It's the most severe type of it, and patients die of pulmonary hyperplasia, or they have mutations in the gene for alpha 1 or pro alpha 2 chain of type 1 collagen. The last disease is Menkes disease. This is an X-linked disorder caused by defective copper transport due to a defect in ATP7A. All right, just know this in case it's high yield. And it leads to low copper because of the defective copper transport, which leads to brittle kinky hair, as shown here, and poor growth, and seizures, and severe neurodegeneration, fatal in early childhood. Oh, there's actually another disease. It's Marfan syndrome. So, just mutations in the fibrillin 1, protein, and it's characterized by impaired structural integrity in the skeleton, the eye, the cardiovascular system. This is shown here as a picture. So there's eye problems. They have long arms, long legs, a short torso, and abnormal chest, and heart and lung problems, as mentioned. All right, this is a quick, a small table to quickly differentiate between the diseases that I've just mentioned. Do go over it as a quick revision if you'd like. And that is it for the second biochem lecture. And with that, there are some questions here just to test our knowledge. So a child presents with bruising eyes and bleeding gums. The slide notes that these findings are due to subcutaneous extravasation of blood caused by capillary fragility. Which biochemical defect best explains this condition? Talked about this. It is the, I'm giving you guys time, lack of dicyl hydroxylation. All right, so scurvy. Another question. A 6-month-old infant presents with brittle kinky hair, poor growth, seizures, and severe neurodegeneration. The slide states this condition is caused by a defect in ATP7A. What is the primary consequence of this defect? All right. So this is mentioning Menkes disease, and it's related to copper. So what is the answer? Low copper levels due to defective copper transport. With that, we're done with the biochem lectures. I hope they served as a good like basis or foundation to what's coming next. We're going to the pathology lecture. First one being the metabolic bone disorders. All right. Now, when we talk about metabolic bone disorders, we have a couple of types. First of all, we're starting with osteoporosis. Osteoporosis is basically when the bones become more porous due to the loss of bone matrix and minerals, as shown in these pictures here. This causes and this makes the bones more fragile and prone to fractures, which I'm pretty sure makes sense. These pictures here show how the cortical bone in a healthy bone looks like, and how it looks like in low bone mass, which is an osteoporotic bone. So there's thin cortical bone and thinner trabeculae. Should be mentioning more. So osteoporosis can be either localized or generalized. Localized in one limb, which is caused by disuse of this limb. Let's say, like, you broke your arm and you you had it in a cast for a couple of months or maybe a year, depending on the fracture. This does cause osteoporosis for this limb. Why? Because physical activity or movement of the bones reduce the risk of this. All right. Next type is a generalized osteoporosis, which involves the entire skeleton or the entire body. All right. The two most important risk factors for osteoporosis are decreased estrogen and decreased calcium. Calcium, how we've always been told to drink milk for healthy bones and so on, of course. But why this decreased estrogen? Actually, estrogen good decreased estrogen shows higher risk of osteoporosis because it affects the pathway, or not the pathway, what is it called, like the whole system of the osteoporosis, which is the osteoclasts, the osteoblasts, and so on. Okay, so osteoporosis can be either primary or secondary. Primary because of excessive bone resorption over bone deposition. Again, resorption is osteoclasts. Depositions are the bone cells responsible to remove the old bone cells or destroy bone cells. So it can have space new cells to come, which is the function of osteoid deposit new bone cells. This is basically the gist of it. But it's the most common metabolic disease of the bone, and it's most commonly shown in postmenopausal Caucasian women and the elderly. Why postmenopausal? Because after menopause or postmenopause women have a decrease of estrogen all of a sudden. This triggers osteoporosis. Okay. The secondary type is due to underlying disease such as Cushing's, due to hypercortisolism, or drugs such as heparin, L-thyroxine, and steroids. And it's actually shown in space travel, which is really interesting, not gonna lie. All right, so what are the factors of osteoporosis? I just mentioned above the calcium and estrogen. There's also increased age, shows increased risk. Decreased activity shows increased risk. That's why physical activity and doing weights in the gym and so on really does help in preventing osteoporosis. Lastly, there's also genetic factors, which like mainly are the key regulators of OPG, rank L, and rank. This will be more discussed in the physiology lecture covered in another crash course. That's why I did not go into depth in here. But this is the gist of it for what you need to know regarding osteoporosis. All right. Clinically, the findings would be bone pain. First of all, this is what the patient will come um, um, about. Okay. And it's mostly going to be in weight-bearing bones, such as vertebral bodies or Colles fracture of the distal radius or femoral neck fracture. And it will also clinically show up as loss of height because of the compression of those vertebral body. And kyphosis. Kyphosis is shown here, which is just this hump of like the upper back and neck and the bending of it. All right. Here are some other pictures. So here are the places where it will be shown the most. Here is the thin cortex and thin turbine and osteoporosis. So this shows that osteoporosis gradually, of course, it does not come suddenly. So it starts gradually in a bone here and there until it invades the entirety of the bone. Okay, how is it diagnosed? The golden standard diagnosis process is DEXA scan or dual energy X-ray absorptiometry. So I've attached an image here to show the DEXA machine, and the treatment of it is weight-bearing exercises, as I just mentioned. They are prophylactic and they are the treatment of it. So it's just lifestyle modification. Also calcium, vitamin D supplements because they're really important to help in like decreasing the osteoclast activity. There's also bisphosphonates, calcitonin, and selective estrogen receptor modulators. These are again pharma, so I won't be going into depth here. Okay. Another disease is osteitis fibrosa cystica. Okay. There's another name for the disease, but I'm not gonna try and pronounce it. But basically, it's caused by secondary hyperparathyroidism. I think there will also be a lecture in physiology, like a part in the lecture of physiology that talks about how hyperparathyroidism affects the the whole synthesis of osteoclasts, osteoblasts, and so on. So inshallah it will make more sense when you go over that. But basically, there are two types, primary and secondary. The primary is because of a parathyroid or a parathyroid hyperplasia, both of which cause high PTH, and this will cause the disease. Or secondary due to prolonged hypocalcemia, such as due to an underlying disease such as renal failure. This will cause high PTH. Why? Because the body is trying to compensate. Okay? Now, this activates osteoblasts, which in turn activates osteoclasts, resulting in bone resorption and a never-ending loop. And yeah, this is the gist of it. I've added some pictures again to show the fibrosis and the osteoclasts doing their work here. There's also osteolytic lesions, as shown here, and it's known as brown tumor of hyperparathyroidism because these brown tumor lesions, osteolytic lesions. All right, this is it for this disease. Next on is osteonecrosis. Osteonecrosis is a vascular necrosis or ischemic infarction of bone and bone marrow. Okay, what are the causes? It's usually vascular interruption or fracture. When a fracture happens, let's say fracture of femoral neck, there would be disruption of the blood vessels, right? So these blood vessels will bleed in, and this will compromise the circumflex artery and cause a vascular necrosis. It can also be caused by steroids, which is actually the most common cause of the osteonecrosis, and usually seen in SLE patients. Why? Because it's an autoimmune disease, so treated with steroids, of course. Um, can also be shown in sickle cell disease. Common sites include femoral head and scaphoid bone. That's why I have a picture of you of going through osteonecrosis here. All right. The morphology of it can be in a medullary or subchondral. So medullary can be in the bone marrow, the cancellous bone, and it's usually clinically silent and stable. Subchondral, however, it's in the subchondral bone, of course. It's wedge shaped, so it shows as a wedge shape necrosis, and it has chronic pain and predisposes the patient to osteoarthritis, which we'll be talking more about later on when we go to the joints part of the crash course. Here are some pictures to show the necrosis and the wedge-shaped necrosis here and there. And in children, it is characteristically show as Lekopf-Perthes disease. So what you need to know about it is that it shows in boys mainly. They would come due to a pain in knee or limb, and when you perform an X-ray or imaging, you'd find necrosis in the femoral head. All right, this is the Lekopf-Perthes disease of children. It's usually found in children. Another disease is collarbone disease. It's aseptic necrosis of navicular bone. So I've added a picture here. That is all you need to know. Honestly, not that high yield. So yeah. With that, we end the first pathology lecture. Now, I hope I'm not going too fast. It's just for the sake of time because this crash course is allotted 2 hours. So I'm trying my best to stick to those 2 hours. Here's a pop quiz. So 72-year-old woman presents with progressive back pain and decreased height. Her exam reveals kyphosis. According to the slide, which of the following fractures is most commonly associated with osteoporosis? Guys, please disregard according to the slide in a question. I don't know how it got here. Anyways, so yeah. So we're talking kyphosis, decreased height, back pain, so many fractures. What is it? Oh, which of the following fractures is associated with osteoporosis? It is the compression fracture of vertebral bodies. It is the most common, all right? So please try not to answer questions quickly in exams. Just the moment you see a fracture and osteoporosis, you might think of there are a couple of other fractures as we talked about. Can be the scaphoid and so on and so on. The Colles fracture too. So please make sure, as it says here, most commonly. So that would, all right. Another question, just so we can make sure we have understood everything. Postmenopausal woman is diagnosed with osteoporosis based on bone density testing. Which of the following treatments listed specifically works by inhibiting bone resorption through suppression of osteoclast activity? Now, this is more of a pharma question, and I did say I'm not gonna go deep into pharma, but this is good, it's good to know as a quick revision. So it's gonna be the bisphosphonates. Yeah. Now we start the second lecture of pathology, and we go more into joint diseases. All right. So this is joint disease number 1. Now, for the basics, joints provide movement and support. All right, mobility, and there are 2 types of joints: solid and cavitated. Okay. The solid are non-synovial. What are they have? Why are they solid? It's because and non-synovial because they lack a joint space and they allow minimal movement. Where would we find these? In the pubic symphysis and the sutures of the and so on. All right. And the cavitated type or the synovial part type is what like we know most commonly regarding joints. So it's the one that has a joint space, that allows for range of motion, and it could be knee joint, hip joint, elbow joint, shoulder joint, so on and so forth. All right. This is the basic anatomy of joint. So you will find the two articulating bones with their articulating cartilage. That would be the synovial cavity containing the synovial fluid. All right. It's encapsulated by a fibrous capsule, first by a synovial membrane and then a fibrous capsule. Okay. Now, what is super important about this like joint space is that it contains the synovial fluid, which is super important. Why? The synovial fluid can actually be your easy way to diagnose multiple joint diseases. All right. So to be honest, like sometimes even like X-rays or imaging won't do you as good as synovial fluid does. So it's just how it looks normally before we go into diseases and how it would look with a disease. It's created by synoviocytes, which are in the synovial membrane, and they're normally pale yellow to clear and viscous. They're rich in hyaluronic acid, which is perfect because we need that to act as a lubricant. So there is no yeah, like it's easier to move basically, and it provides nutrition for the articular cartilage. Now, arthrocentesis is the process of the aspiration of the synovial to diagnose a joint disease. Okay, before we go into the synovial fluid, let's just lay some very like quick medical terms that we need to know here for joint diseases. So arthritis is the inflammation of the okay, because arthra is joint in Greek and itis is inflammation. We all know that. But monoarthritis from mono means one joint is involved, okay? Oligo is multiple joints. So no, I'm sorry, 2 to 4 joints, okay? Poly is multiple, so it's more than 4. Why do we need to know this? Because this is like particular. Let's say monoarthritis shows in septic arthritis and crystal arthropathy. Oligoarthritis shows in spondyloarthropathies, and arthritis shows in rheumatoid arthritis. Right? We'll be digging more into these later on, but for now, synovial fluid analysis that I was talking about. Okay, so it is a routine study to do when shows shows up to the clinic arthralgia or joint pain. Okay. On gross appearance, it's, as I said, normally pale yellow. This is how it normally looks like. This is how it would look like if we have an infectious arthritis. Okay, you can see blood. You can see like some other abnormalities. Okay. From that, we can not only like study it grossly. We can also study the W and differential. No, it's less than 200 cells. And neutrophils is less than 25% of the total count. We could also perform culture and gram stain on it. So this is only if infection is suspected. It would show what type of organism are we dealing with. And crystal analysis, super important. Why? Because this is needed. There's crystal deposition and so on, so forth. Okay. For example, like gout and so, as we mentioned. Now, synovial fluid in different disorders shows differently. Okay, this is a very nice table here that shows those differences. I do it well or understand it well. It does really help. I remember having good amount of questions about synovial fluid that I answered using this table. So it shows the difference in color, viscosity, WBC numbers, polymorph nuclear leukocytes, tissue or percentage, I mean, and culture. All right. this is classified depending on the groups or classifications of joint diseases. Now, those classifications are what we're going to be discussing in this next lectures of pathology. First group is group 1, degenerative. It has osteoarthritis and neuropathic Charcot joint, which we'll be discussing. Group 2 is the inflammatory type. We'll be discussing the rheumatoid arthritis, the ankylosing spondylitis, Writer's disease, and we have already discussed gout. Pseudogout and psoriatic arthritis will be discussed more in the clinical part of the joint diseases. Okay, group 3 is the septic one, which means the infectious one. It has infectious arthritis due to viruses. Group 4 is the hemorrhagic one due to hemophilia, trauma, and scurvy. We'll not be going deep into group 4, to be honest. We did already mention scurvy, inflammatory. Hemophilia is more heme block related. So we'll be digging more into group 1, group 2, and group 3. All right? Group 1, degenerative disorders, starting with osteoarthritis. Characteristics of osteoarthritis are going to be, first of all, it's age dependent. So it shows after 65 years of age. Okay? Mainly in women. So the shows mainly in men. Osteoarthritis shows mainly in women. I think we could say maybe that most of the joint diseases do show more in women. Okay? It's also happen mostly in the weight-bearing joints. When we say weight-bearing, knees and hips, or the distal and phalangeal joints of the hands. All right? Now, osteoarthritis is also has also two types or two groups. The primary and secondary. Primary one is the result of aging phenomenon, normal wear and tear. So the patient could be just predisposed to genetic factors such as RNX2 as the age, especially 65, a osteoarthritis. As for B, secondary, it's result of predisposing conditions such as trauma, obesity, and hemochromatosis. All right? Now, how it goes is we start with okay, normal. In a normal joint, cartilage is lubricated by the synovial fluid, as we said, and cushions the bones and allows frictionless motion. Right? Great. Then, due to trauma, what different causes will cause thinning of those articular cartilage, as seen in development of cracks, which is process called fibrillation. Okay, this is those cracks are seen here, cracks of the cartilage itself. Okay, then these will cause erosions and loss of cartilage. Okay, as seen here, and later will form loose body, also joint mice, and subchondral cysts. We can see them here. This is with synovial fluid and loose bodies. They're floating in the synovial fluid. All right. Lastly, and finally, it will cause it's the a lot of the normal cartilage surrounding the bones, sclerosis, also because of the change in the synovial fluid and the inflammatory cytokines and everything. There will also be no joint space because of the formation of the osteophytes. What are osteophytes? They are these abnormal formations for cartilage, and they disturb the joint capsule, and they disturb the motion or the mobility of the joint. All right? This is basically the pathophysiology of osteoarthritis. All right? Pathology would be what we just mentioned. So erosions and clefts in articular cartilage. fragmentation of the cartilage, subchondral bone cysts, we just mentioned, it's visible on X-rays, and hibernation, which when the bone rubs on bone, so gives a polished ivory-like appearance. All right. Here's how it will look on like no like real life. So here are the osteoformation, articular surface, the subchondral cysts, and the residual articular cartilage. All right. In summary, those changes in the osteoarthritis joints are shown here. Now, why did I include this? Because I believe when Dr. Uban shows or like has slides like these, it serves really well as a good like SAQ question on. It could be an SAQ case about osteoarthritis, and then he would say mention for pathological findings seen in this patient's joints. So this slide would come in handy then. All right. So please do focus on them. Now the clinical findings or how the patient would show up in clinic. First of all, the fights that we just will cause. Okay, those are two very important nodes that you need to know when it comes to osteoarthritis. First of all, the Herberdens nodes. These are found at the base of the distal um, here are they. Okay, so distal interphalangeal. The Butchard's nodes are in the proximal interphalangeal. So they are those here. Okay, so the ones more proximally are Butchard's. The ones more distally are Heberds. I'm not very sure about the pronunciation, not gonna lie, but just know how they're written, what are they, and which. A very good way to memorize it, I think I memorized it this way, is H and D, because H and BP, because they make sense better, like BP, you get me, and HD. I think it makes sense for me only. I don't know. Pain is also a very important clinical finding in the patient. It would be usually with passive motion of the joint due to the synovitis of that joint, and stiffness, of course, and cryptus. Okay. Um. All right. Now, clinical follow-up. The synovial fluid analysis would be normal. By protection, there is no bone, there is no microorganism or anything that would show. The synovial fluid itself is normal. You will find osteophytes, the joint space narrowing, the subbone cysts, and the fusion of the joints. All right, here are some pictures, and like this, we finished the first degenerative disorder. The second one is neuropathic, which is Charcot's joint. Okay, Charcot is a non-inflammatory joint disease to a neurologic disease, which causes destruction to the joint due to insensitivity to pain. So basically, when you don't eat somewhere, you would pose it to more harm or trauma because you're not aware of the pain that's caused there. That's why there would be a pain or disease happening there. Just how it is when it comes to diabetic foot ulcers, because they have neuropathy in their foot, they have loss of sensation. That causes them to harm their foot or not feel ulcers or pain there. All right. The pathogenesis is loss of proprioceptive sensation, which leads to recurrent trauma, and progressive destruction and disorganization of the joint. Okay? Proprioception is basically the feeling of the joint in space, the orientation of it. Where is it? You get me? If it's like moving up, down, and so on. And deep sensation. Okay? The cause of the joint could be diabetes mellitus. I just mentioned this. Why? Diabetes mellitus does cause neuropathy. So it's actually most common cause of Charcot's joint. And the syringomyelia this will show in shoulder, elbow, wrist joints, and tabes dorsalis. Okay. Picture here showing the charcot joints destruction, okay, of the knees. With that, we're done with the this pathology lecture, the first pathology lecture on joints. So here's a question. A 68-year-old woman presents with pain, worse passive motion, and bony enlargements at the distal interphalangeal joints. Which of the following clinical features from the slide is correctly associated with osteoarthritis? And pause or think. So, pain worsened by passive motion, stiffness, and bony enlargement. What is a clinical feature that would show? It is the Herberdens nodes at the DIP joints, okay? So, some question, like, let's, if they were to bring a question, but the choices would be Herberdens nodes on the proximal interphalangeal. That would be, please make sure to check which joint has the disease that you are looking for. Okay. The second, or the finding, I mean. The second question is, which of the following pathological findings is characteristically seen in osteoarthritis? So there's planus formation, synovial proliferation, the monosodium urate crystals, and progressive loss of articular cartilage. The answer is D. Monosodium urate crystals are for gout. Planus formation, will be talking more later about that. All right. Okay. With that, we will start the third lecture of pathology, which is joint diseases 2. I think after this lecture, we'll be halfway done with the crash course. So yeah, bear with me. All right. Group 2, inflammatory disorders. And we'll start with the rheumatoid arthritis. Okay. Rheumatoid arthritis is a female predominant disease. It's multifactorial, chronic, systematic, inflammatory, shows in women aged 30 to 50 years. Okay, most commonly. It affects peripheral joints, producing synovitis, ankylosis, which is basically the fusion of the joint. Now, there are different manifestations of rheumatoid arthritis. It could be articular, which means related to joints, or extra-articular, which means like outside the joints. Okay? So articular are joint changes, extra-articular can be skin, blood, vessels, organs, changes, and manifestations. Okay? Now, advanced cases of rheumatoid arthritis produce joint deformities other than the ones we just mentioned. So please focus on the differences of these. There is no nodes of Buchner's or not Buchner. I'm sorry, what was the other one? The Herbert's. Again, I don't know how they pronounce that, but just please know how to recognize it. Okay, so I know which clades are seen in which disease, because they might look similar, but you do not want to mix them up. Okay, so in advanced cases, you would see radial deviation of the wrists and ulnar deviation of the finger. What does that mean? Radial, basically, it's going into the direction of the radius. Okay, so that is the radial deviation of the wrist. Okay, shown in the picture. And ulnar deviation of the fingers, it's seen here, also going to the direction of the ulna bone. Okay. There's also swan neck deformity, which is seen in the distal interphalangeal joints, as flexion, and in the phalangeal joints as hyperextension. Okay, so it's a very specific finding that you need to understand and memorize. I remember we've had a question that was talking about swan neck deformity. However, they flipped it, hyperextension of DIP and flexion of PIP, so that was wrong. Okay, so please do focus on those details. Lastly, there's the Boutonniere or Boutonniere, I don't know, I think it's Boutonniere deformity. So it's the flexion of the PIP and extension of the DIP. Okay, It's all here. Now, this rheumatoid arthritis, the pathological mechanism of it is basically so first of all, there is a mutation that happens, okay? So the patient would be genetically predisposed to rheumatoid arthritis. They have some gene mutations that we'll be discussing in a bit, and they were exposed to specific environmental factors. Now, these environmental factors will um trigger rheumatoid arthritis. How? When this happens, there will be a mutation in the DNA from arginine to serine. Okay? This is called self-protein stylation. Okay? When this happens, the body doesn't recognize the protein anymore. And when that happens, it will, of course, send antibodies to attack it because it's a foreign body now. And when those antibodies are formed, they go through blood vessels to the joint and they start attacking the joint. Okay? They basically recruit the interleukins, interferon gammas, and so on to attack the joint. That was bone and cartilage erosion, increased synovial fluid, and pannus formation. Pannus formation is really, really important when it comes to rheumatoid arthritis. You need to know like it's a high yield term that is used in rheumatoid arthritis, okay? So chronic synovitis, pannus formation, fibrous and bony ankylosis, and joint deformities. Here is how it looks normally. Here's how it looks with rheumatoid arthritis, okay? Now, the systemic feedback, I mean the extra what was it called here? The extra-articular manifestations of the rheumatoid arthritis are going to be fatigue, weight loss, low-grade fever, and rheumatoid nodules. Different from the other nodules that I mentioned again. These are cutaneous lesions in the forearm and elbow, may be also found in the lungs, spleen, and heart. Under microscope, they show central zones of fibrinoid necrosis. A picture that show I'm discussing, okay? Rheumatoid, when you want to diagnose it, you first send for lab investigation, okay? Upon lab findings, elevated ESR, and most importantly, polyp factor and ACPA. Now, ACPA is the most sensitive antibody to be found, okay? When you find ACPA, خلاص, automatically it's rheumatoid arthritis. So what's ACPA? It's the anti-sterolate protein antibody that we just mentioned above that forms, and the rheumatoid factor is another antibody that is involved in rheumatoid arthritis. And synovial fluid, again, because synovial fluid, as I mentioned above, is very important or very handy in these types of diseases. It will show high WBCs and an infiltrate of polymorphonuclear cells. Okay. Upon X-ray, it will show erosions of the articular deformity, and the genes that are important in the rheumatoid arthritis are the HLA-DR, especially DR1 and DR. Super important, okay? Can come as an MCQ, an easy correct answer, okay? Now, what are the factors causing joint destruction in this type of arthritis? It could be neutrophils. This is the slide that I added here because I thought would be important, and again, good MCQ question or SCQ question. And neutrophils and their enzymes, pannus formation again, the CD4 positive T cells. This is what I was what I was referencing to when I mentioned the body attack and so on, because of course the T cells come first and then the B cells and the antibody formation. M1 M2 imbalance, activated osteoclasts, and the antibodies that we mentioned, the RF, which is a rheumatoid factor, and the ACPA. Okay. There is a syndrome that is related or that usually comes with rheumatoid arthritis. What is it? It's Sjogren's syndrome. Sjogren's syndrome is an autoimmune destruction of lacrimal and salivary glands associated with RA. Why? Because both of them are autoimmune diseases or syndromes and so on. Clinical findings will show dry eyes because of the destruction of these lacrimal and lacrimal glands. So keratoconjunctivitis sicca and dry mouth because of the destruction of the salivary gland, which is xerostomia. Okay. With that, we end the lecture of pathology or joint diseases. So, which of the following deform specifically associated with advanced rheumatoid arthritis, as shown on the slide? I'm gonna give you guys a minute. Okay. Okay. A patient with rheumatoid arthritis presents with dry, gritty eyes. We just talked about this. Okay. Which of the following is the most likely associated condition? We just mentioned the disease or the syndrome that's related to dry, gritty eyes, Sjogren's syndrome, so it's keratoconjunctivitis sicca. Okay? Now we go to the final pathology lecture on joint diseases. Okay? We still have another lecture for the tumors. But for this pathology lecture of joint diseases, we'll finish the groups of the disorders of the joint. So we finished the degenerative bones, starting with the seronegative spondyloarthropathy. Okay, what are those? They are a group of diseases or joint diseases that have genetical predisposition to them, plus environmental factors such as stress, infections, and so on. Okay, so characteristically, it has RF negative, which makes sense because we just rheumatoid fact it shows in rheumatoid arthritis, and we finished talking about that. Okay, so here it's RF negative, but it's positive for HLA BT. This is the HLA that was shown above. So they might look confusing, but please focus on them and try to memorize them really well. Okay? It's it's not female dominant. It involves sacroiliac joints and vertebral columns. And it has similar clinical feature. They like all those groups of diseases have similar clinical features, okay? The three diseases are part of the are ankylosing spondylitis, Werther syndrome, arthritis associated with ulcerative colitis, trichinosis, or psoriasis. Okay? We'll be discussing all of these. First of all, ankylosing spondylitis, which is also called Mary-Stample disease. No idea why is it called like that. First time hearing it, to be honest. I do not remember, but thought I should mention it. It happens in young men, peak at 20 years, who are again HLA-B20 positive. Keep mentioning it in every disease of the spondyloarthropathies. Why? So we can memorize it, okay? It has bilateral sacroiliitis, causing and morning stiffness. Super important. Morning stiffness. Why? Because not morning stiffness or pain is with other diseases, such as gout and so on. So morning stiffness is a very good indicator of spondylitis. Okay? Because the disease usually peaks at night, so first wake up, they would be in pain the most. Okay? And as this disease goes on, there will be fusion of vertebra, which shows as a bamboo spine, X-ray, or the imaging, and causes forward curvature, okay? Because there will be less mobility. and this may cause aortitis and uveitis. So inflammation of the aorta and inflammation of the eye, which will cause blurry vision. Okay, here's a picture of the bamboo. Uh, disease of the spondyloarthropathies is Reiter syndrome. Reiter syndrome is super high yield for even like USMLEs and so on. So again, it's young men, 20 years, who are HLA-7 positive. خلاص, we're memorizing it now. And the environmental triggers include chlamydial, urethritis, and intestinal infection with Shigella, Salmonella, Campylobacter, or Yersinia species. Now, you guys just finished POD. You'd know better than me here. But basically, what we mean is that there will be an infection which will trigger the disease. Okay? There's very known triad that comes with Reiter's disease. It's urethritis, conjunctivitis, and arthritis. So urethritis, which is the inflammation of the urethra in a male due to the chlamydia tract infection. Conjunctivitis, which is infection of the conjunctiva and the eye, and arthritis, infection or inflammation of the joint. Okay? Seronegative. This is like a lab finding, okay? To remember that, we always say, or it's a like the mnemonic that comes with it, can't see, can't pee, can't climb a tree. So can't see, conjunctivitis, can't pee, urethritis, can't climb a tree, um, arthritis. Okay? Attach some visual figures here to help you memorize. But here are other findings that you can see. So there's ulcers in the foot, and feet, meaning both, glands, penis, um, in the mouth, and so on. Infection of the eye, infection of the joint, and so on. There's also, as we can see here, Achilles tendonitis. Okay, and the lesions that I just mentioned, as in like the painless ulcer in the penis and the dermabilionargia, it's basically just I think it's the one referenced here and here. It's basically a skin lesion. Okay. This pattern, Reiter syndrome, than the other ones. So here it starts a few weeks after the infectious episode, whether it was again any of the microorganisms or infections that basically it will start as low and then to sacroiliitis, okay, in the sacrum. This is why there's a sacrum picture here. So I hope this whole picture is now clear to you. Okay, the last type of under the entity of spondyloarthropathy, seronegative spondyloarthropathies, is enteropathic arthritis. Enteropathic, from its name, entero means intestines, okay? Pathic, and how is it related? Basically, again, a patient who would be an HLA-B27 positive, okay? It's and also has IBD, inflammatory bowel disease, and C, ulcerative colitis or gastroenteritis, okay? Would show up to the clinic with arthritis. Now, the pattern or the character of the arthritis is migratory. That means it moves. And oligoarthritis, we mentioned that before. Oligoarthritis means 2 to 4 joints, okay? It may resemble ankylosing spondylitis, but it's less severe and remits spontaneously in a year or two. Great. Now we've finished with group 2, is the infectors. Group 3, and the final one that we're going to cover, is septic disorders. And starting with infectious arthritis. Honestly, there is no ending. It's just infectious arthritis, so it's just that. Yeah. So infectious arthritis is inflammatory type of arthritis secondary to a microbial and pathogen infection, as stated in the name itself. It's uncommon, but it can rapidly destroy a joint, and it's usually monoarticular. What do we mean by monoarticular? We did cover that above. Means it's one joint, which does make sense. The rule of thumb in medicine, or in like joint diseases, it can also be like referred in medicine generally, but basically, when a joint is inflamed electrically, so side, it's it's not that whole side. It's just one place. It makes sense that it's not a systemic disease, so it's not autoimmune. Because if it's autoimmune, the the antibodies won't pick and choose. Like it's gonna attack all the joint. So autoimmune is gonna be symmetric. It's going to be oligoarticular or so on, even. But if it's an infection, the infection could like spread to only one place. That's very and makes sense. Then the spreading can either be hematogenous, so through blood vessels, or direct inoculation. So it's because surgery or an injection, like when like some of the treatments that are given to joint diseases, like patients with joint diseases, they give them infection like injections directly to the joint space. Okay, so if needed easily, the joint will also be infected. So infectious arthritis also spread from a nearby focus of infection. So it could be, for example, infection of like any like that could spread there. Okay. On synovial fluid analysis, you will see yellowish green color. This shows infection, and of course, a high count. Sense. The neutrophils would be more than 7% of the total WBCs, and it's usually caused by two like bacterial entities. The non gonococcal arthritis. The Okay, so for the two types, there is non-gonococcal arthritis and gonococcal arthritis. The non-gonococcal is most common in the knees, and it's extremely destructive of the joint. The majority is caused by organisms such as Staphylococcus aureus, H. influenza, or E. coli. Okay? The gonococcal arthritis, from its name, it's caused by Neisseria gonorrhea. Okay? And it's the most common cause of septic arthritis. It produces disseminated gonococemia, which is associated with tenosynovitis, which is um, inflammation of the sign of like fluid or so on, synovial space, and dermatitis. It's usually in young women with deficiency of C5, C9. Now for the next arthritis, like infectious arthritis, it's Lyme arthritis. It's caused by Borrelia burgdorferi, and it's transmitted by bite of Ixodes tick. There is this like organism is usually the white-tailed deer, and early disease shows up as a skin rash with erythema. Okay, specifically as skin circles around the tip of the tick bite, shown in this picture. So it shows as a bull's eye. This is how it's usually like described. Okay, and late disease of the Lyme arthritis would be arthritis, bilateral Bell's palsy, and myocarditis and pericarditis. Diagnosis would be reached by serology tests, culture biopsy, and silver stains of the synovial biopsy. Here's the tick embedded in the skin to show the like how it looks like. Okay. With that, we're done with the joint diseases. We're good. And here's a quick question. Okay. So a 24-year-old man develops low back pain and sacroiliitis a few weeks after a intestinal infection. On exam, he has painless penile ulcers and scaly plaques on takes on souls. Now, which addition finding is characteristic for Reiter syndrome? خلاص, we have came to the conclusion that this is Reiter syndrome for fact. Okay, painless penile ulcers, osteomyelitis, there's scaly like sole skin lesions, and all. Which of these following is also characteristic of Reiter syndrome? I'm gonna give you guys a moment. Achilles. We mentioned it. Okay. Another question is a 32-year-old woman presents with septic arthritis and a pustular dermatitis rash. She's found to have a deficiency of the complement C5, C9. According to the following choices, which is the most likely causative organism? What's gonna be? Neisseria, gonorrhea. Okay. Now we're halfway done with the course, and we're going to start with the last pathology lecture, which is the pathology of bone and soft tissue tumors. Now, the good news is that after that there is clinical. The clinical we is very light and brief, because most of like the bulk we have gone over in the pathology. So inshallah it will be easier from here. Okay, this is just as a motivation for you to go through. So for the bone tumors, we have benign and malignant. This is the classification for almost every tumor. Okay, the malignant has primary and secondary types. Secondary always usually being a metastatic form. Okay, now metastasis is the most common malignancy of bone. So whenever you hear of bone malignancy cancer, you think of it as a metastasis. Okay, it's not usually primary. It's not usually the primary site of the tumor. Okay, most commonly this metastasis comes from breast cancer or prostate, lung, kidney, and thyroid. Okay, the nature of metastasis can be different. It can be osteolytic or osteoblastic. Osteolytic refer to osteoclast, so it's the destruction of the bone. So it's destructive, and this is how most metastases are. Mainly the breast. Osteoblastic is reactive, new bone formation, from the word blast, and it comes usually from prostate. Okay, here's a picture of the osteolytic metastasis, as seen here, and here is the picture of an osteoblastic metastasis. As you can see, osteoclastic or osteolytic, there is destruction of the bone. Osteoblastic, there is actually increased density or increased bone formation. Okay, now the locations of the tumors or the bone tumors, really important to know, because it can like turn the exam. So if they question where to like define the location of the tumor, خلاص, you can narrow it from there. Okay, so the benign tumors can be seen epiphysis, the metaphysis, the diaphysis. Epiphysis is the up, the metaphysis is around the neck, or it's around the metaphyseal plate, and diaphysis is in the shaft or in the middle of the bone. Okay, malignant tumors usually show in the diaphysis or the metaphysis, not in the epiphysis. Now here are all the tumors mentioned, and we'll be going through them. So the tumors can also be classified by age, and this is also another giveaway for you in the question exam. So here I've written down the ages that are like characteristic for each of these tumors. Do go through them, okay? But for the sake of time right now, I'm just going to skip. Okay, so these are duplicated by mistake. I'm sorry. So I hope you can read them. So بس ان شاء الله I'll fix them and I'll send the slides. So primary bone tumor, the most common one is osteosarcoma. Okay, please remember that. It's very easy to ask about the most common. So most common primary bone tumor is osteosarcoma, and the risk there is radiation and familial syndromes. The treatment, if it's benign, the benign tumors can be treated by curettage, or like the burning of it, or the removal by like, I don't know how to describe it, to be honest, and packing with bones. Okay. Um, I don't know where did the malignant part get removed, but basically the malignant tumors, I'll fix the slides and send them, but basically the malignant tumors can be treated by resection and chemotherapy. Okay? Surgical resection. All right, now the classifications of the primary bone tumors, so we can start going through them one by one. Okay? Um, there is osteogenic, chondrogenic, unknown origin, hematopoietic, fibrogenic, histiocytic origin, notochordal, vascular, lipogenic, neurogenic. Okay? Some of the tumors are listed under each of the classifications as benign, malignant, and so on. But we'll be going through them um as major entities, memorize them better. Okay? Starting with the primary bone tumor, osteogenic, benign. Okay? So first one is osteoma. Osteoma is a tumor of like a benign tumor of adults, so around between 40s and 50s. It's usually occurs in the skull, fish bones, and jaw, such as those pictures shown here next to the teeth. They're harmless. However, they can impinge on like nerves, brain, and sinus drainage, and so on. It also very commonly shows up in the sinuses. Okay, it's histologically normal, but if multiple of them is seen, do suspect Gardner's syndrome. I'm not going to be going details for that. You don't need to confuse yourself. Okay. The malignant osteogenic bone tumor is osteosarcoma. So that one is osteoma. This one is osteosarcoma. Usually, when you see sarcoma, it refers to malignancy. Okay. So osteosarcoma is the second most common primary malignant tumor after multiple myeloma. Okay, memorize it. In the metaphyseal region, it happens in the metaphyseal region of the long bones, as seen over here in the picture, and it causes local pain, tenderness, and pathological fractures. Its age is bimodal, so it shows in two age groups. First one being 10 to 20 years old. It arises de novo, and the genes of it is like the genes causing it is the inactivation of the retinoblastoma gene, or the RB gene, in Leferman syndrome. The second age group, which is above 40 years old, is usually secondary to one caused by a mutation of this SQSTM1 in both, and it shows in both flat and long bones. Okay. Grossly, how it will look like, it will have white mass areas of hemorrhage and necrosis. First. Second, there will be cortex like destroyed, and this invades the adjacent soft tissue. Okay, also seen in this picture here. So the cortex, the adjacent tissues are invaded. There will be it will elevate the perineum and produce the Codman's triangle on X-ray. This is the Codman's triangle on X-ray portrayed here. Can easy picture, MCQ picture, so please do memorize it. I think it came for us. Okay. The sunburst appearance due to calcified osteoid extending into the adjacent soft tissue is shown here. So this is just like define the appearance. Sunburst. Do of the appearances, like above we talked about bamboo spine, so on and so forth. It could either be the answer to a question or mentioned in a question, which will an answer. Okay. On microscope, it shows osteoid and spindle shaped cells showed here. So spindle shaped cells and osteoids. This whole thing here that is formed is the osteoids. Okay, it spreads through bloodstream, and its treatment is, as we said, because it's malignant, so it would usually be resection with chemotherapy. Prognosis is 5 year, survival rate of 50-60, so it's good. Um, uh, the going to, I mean osteogenic, sorry. We're going to the chondrogenic. Chondro is the prefix to cartilage. Chondro, we talk about cartilage. And benign. So the first one is gonna be osteochondroma. From its name, you can like differentiate. Okay? And since there's no sarcoma suffix, so that means it's not malignant. Okay, this is just an easy way to like differentiate between them. Okay, so characteristics of it would be first of all, it's the most common benign bone tumor. This is first. It's hamartomatous proliferation, so it's that's how it's spread. The, there's symptomatic lesions that show um and prior to 30 years of age. Okay. Um, they arise mainly it's in the distal femur, as shown in this picture, and it could be associated with two diseases. First of all, this is Olier's disease. This only shows when there is multiple enchondromas, and Maffucci's syndrome, which is multiple enchondromas, hemangiomas of soft tissues. Okay. I've added some pictures here of the osteochondroma. So, cartilage deposition. Again, cartilage. Like abrupt cartilage deposition that is very messy. And here are the cartilage cells, chondrocytes. Okay, easily differentiated under a microscope. That was the benign one. Malignant chondrogenic tumor is chondrosarcoma. Because from I think by now we can easily differentiate tumors from their name. Chondro, so cartilage. Sarcoma means malignant. Characteristics of it, it's the most common primary malignant cartilaginous tumor. It shows in ages 40 to 60. The location is central skeleton or the upper end of femur and humerus. So as shown here, this is a femur. Okay? Can arise de novo. De novo means like from itself, by itself in the body, or secondary to osteochondromatosis, which is another disease. Okay? 75% of fires are aggressive but with metastasizing potential. Um, the gross image would show grayish blue, glistening, symmetry, translucent cells. These are the chondrocytes. Okay. Um, under the microscope, it will show atypical chondrocytes and with multiple nuclei in a lacuna. Biologic behavior and prognosis depends on the grade of the tumor, as we said, to the lungs. Okay. Now the other group, which is uncertain origin, like tumors of uncertain origin. First one is Ewing's sarcoma, super high yield. Characteristics of it is basically, first of all, it's extreme malignant tumor composed of small round blue cells. Please do memorize this. Small round blue cells. It arises within the marrow cavity in the diaphysis of the long bones, as seen here. Okay? And it's probably of neuroectodermal ectodermal origin. Why we say probably, we're not sure. Okay? Its specific translocation is T11 to 22 and gene fusion of EWS and LI1. It most occurs in teenagers 5 to 20 years and produces white tan mass with necrosis and hemorrhage, which yeah, we can see here. white tan mass with necrosis and hemorrhage. X-ray, it will show concentric onion skin layering of the new periosteal bone. Super high yield picture. Super high yield characteristic finding, okay? Presents as an infection. Radiation, chemotherapy, and surgery are the treatment of the Ewing sarcoma with a 5-year survival rate and 75% prognosis, okay? Here are the small blue round cells that we mentioned here, just here, and the skin layering and the site. Other tumor is giant cell tumor. It's also called osteoclastoma. It is locally aggressive tumor composed of multinucleated giant cells admixed with mononuclear cells. So non-neoplastic and neoplastic. That's why there's giant cells and mononuclear cells. It's usually seen in females more than males, age 20 to 40, and the epiphysis of long bone. It shows solid red-brown mass with hemorrhage and cystic degeneration. And the X-ray shows soap bubble appearance. The soap bubble appearance is shown in this X-ray above. So, lined by this line is the soap bubble appearance, and yes, this is how it look like under the histology slide. So, multinucleated giant cell is this one here. So, from its name, giant cell, multinuclei, okay? Mixed with mononuclear cells all around. All right, perfect. With that, we are done with pathology. Finally, so here is a question. Osteosarcoma most commonly occurs in which location? Osteosarcoma, from its name. Sarcoma is malignant. Okay? So it is the bone tumor under the osteogenic malignant entity. It usually occurs in the metaphysis of the long bones. Okay? Another question is, according to like the previous slides, which statement correctly describes osteochondroma? Osteochondroma, from its name, bone, cartilage, benign, because there is no sarcoma. Okay? It's A, B, or C, A, B, C, or D. It is a common benign bone tumor. Okay? With that, we're done with pathology, and we'll start with the clinical. Now, clinical first lecture is about the metabolic bone diseases. As a disclaimer, I've already said this, but most of the information that was covered in the clinical lectures, all have already covered in the pathology lectures that we're done with. That's why when I went over the clinical lectures, just so I don't repeat slides and information and waste time, I only add slides that were not included in the pathologies, and just because doctors usually tend to add more stuff, elaborate more, talk more about the management, the treatment, and so on. So that's why it might look haphazard. It might feel like it, but inshallah, if you add on to you think of it as like adding on to the previous information, inshallah, it will be good. So first of all, the types of the metabolic diseases of the bone. We have 4 types, okay? Osteopenic diseases, which is generalized decrease in bone mass, osteopenic. This is usually osteoporosis. This is a very great example. Osteosclerotic disease, which involves an increase in bone mass, which is sclerosis. Osteomalacia disease, which is an increased ratio to the mineralized fraction. So it's weakening of these bones. And osteomalacia is the main example. Last one is mixed disease, combination of osteopenia, osteomalacia with hyperparathyroidism, listed as an example. Okay, we did mention hyperparathyroidism before. Now, secondary osteoporosis, believe we did not touch upon in the pathology lecture. Basically, secondary osteoporosis, lifestyle factors, medications, gastrointestinal and hematological factors. I thought of mentioning them just in case they were to come in an exam. So lifestyle factors would of course be smoking, alcohol abuse, low calcium intake, and vitamin deficiency. Hyperparathyroidism, we mentioned that pathology lecture. There's also hyperthyroidism because it's linked to hyperparathyroidism. Diabetes mellitus and Cushing's syndrome. We did mention Cushing because of the hyper cortisol. And medication, glucocorticoids. We mentioned steroids before, remember, in the SLA. Anticonvulsants, anticoagulants, and aluminum or antacids. Gastrointestinal, celiac disease, IBD, GI surgery, malabsorption, and hematological multiple myeloma, hemophilia, thalassemia, and leukemia or lymphoma. The screening of osteoporosis is done just to like as prophylaxis of a patient, and so it's recommended access in women of 65 years old, like above or equal to 65 years old, years of age, or women that are less than 65 years of age but have an equivalent risk due to a criteria, like afraid from a criteria, okay? The risk can be estimated using the fracture risk assessment tool, okay? Now I believe that this risk assessment tool is not really important here. Do not have to confuse yourself here and memorize it because it was not mentioned in the slides, but just know that. And again, why DEXA? Because it's the gold standard diagnosis tool, okay? It can be also used as a screening. The laboratory analysis of osteoporosis, you would order a CBC, of course, serum calcium, and a phosphate ion. This is to check for the parathyroid and thyroid, so on. 24-hour urine calcium again, renal and hepatic function tests, vitamin D, as we said, vitamin D deficiency has a role, and TSH and PTH, these are hormones related to the thyroid functions, okay? This graph shows the scoring system of the DEXA scan and how it can classify it to different diseases. So normally, DEXA scan would give you a T-score of more than -1. This like if it's more than -1, خلاص, it's okay, you're reassured. If the T-score is between -1.5 to -2.5, leukemia. Early stages of osteoporosis, okay? So if the patient is advised with lifestyle changes and they reassess of years and they take care of themselves and all of the lifestyle modifications that we talked about, خلاص إن شاء الله it won't go proceed into osteoporosis. But osteoporosis shows a T-score of less than, so it would be -3.5, -3, and so on. Now here, of course, you need to start drug treatment, but again, give lifestyle advice. So you try to hinder that disease as much as possible. Okay. Now we're done with the first clinical lecture. Of course, there's a question. So, which metabolic bone disease combination of osteopenia and osteopenia? That would be an example would be hyperparathyroidism. Which of the following patients meets the criteria for a one-time DEXA screening? Take a good look at the ages, the risk factors, and so on. Okay? So it is D, a 67-year woman with no other risk factors, because she's above 65 years of age. Or it could be less than 65 years of age, but risk factors, okay? Mild joint risk factor, it's okay. It's normal. It's treated وخلاص, that's it. Normal BMI, no fracture history is not a risk factor, and so on, okay? Now for the second clinical lecture, osteomyelitis. Osteomyelitis is of the bone. From its name, osteobone, itis inflammation, and bone of the bone and the bone marrow by an infecting organism, and it can be localized or it can spread through the bone involving, such as the marrow, the cortex, the periosteum, and the tissue. It's found more in men than women. It increases with age, and the infants and children can have it like located in their long bones, such as tibia, femur, and humerus. Um, Adults can have it in small bones, such as vertebra and pelvic bones. Now, osteomyelitis can be spread in three ways. Okay, so there's hematogenous spread or seeding. This is the most common through blood. Direct inoculation of infection, summer surgery, I mentioned this, or contiguous spread. So it's spread from a nearby infection. Okay. Osteomyelitis can be caused by different organisms. I've added this table here to show you organisms. So there's Staph aureus, Pseudomonas. Staph aureus is actually the most common, 80 to 90%. So this is the vast majority. Then there is Pseudomonas. This is usually UTI, nosocomial, TB, Salmonella, so on and so forth. Do go over it. Okay. The risk factors of osteomyelitis are diabetes mellitus, um, compromised immunosuppressed, um, peripheral vascular diseases, sickle cell disease, sepsis, open fractures, IV drug use, and joint prosthesis. So like it's like acts as a foreign object in the body. The pathophysiology of osteomyelitis starts with an inflammatory exudate in the marrow, okay, in the bone marrow. Then this will cause increased pressure in the intramedullary space. Then the exudate will start seeping to the into the bone cortex, and the blood supply is interrupted, leading to necrosis. This is a bit similar to the osteonecrosis that we talked about. Okay? And like that, the bone becomes dead because it's not receiving its blood supply, and so okay. It can be classified into four different superclized and diffuse, and patient would present with fever, chills, localized bone pain, swelling, warmth, and redness. These are all signs of infection. Okay. Limit of nearby insulin, this would be irritability or refusal to bear weight, use the limbs, such as like walk or stand or so on. Okay. On physical exam, you would see localized tenderness over the affected bone, swelling, warmth, and erythema, limited range of motion, possible range of the sinus tract. Diagnosis is on WBC, you'd see increased WBC count, in acute and normal and chronic. ESR and CRP are non-specific, they're good for monitoring after diagnosis. X-ray is normal first 2 weeks. Um, um, there would be lytic areas surrounded by sclerosis afterwards. You could also use CT scan, MRI, nuclear medicine imaging, and so on. You could also use blood culture and bone biopsy and culture diagnostic. Okay. On imaging, you will see this for osteomyelitis. Okay, this can come again as an OSPO or MSQ. It is basically a subcortical abscess due to the infection. Another entity is Pott's disease. Pott's disease shows as fever, back pain, night sweats, weight loss, and Pott's paraplegia. What is it? It's a neurological malady. It shows as a cottage cheese appearance or caseating granulomas on fast stain. There is compression fractures and loss of height, cold abscesses. It shows in the thoracic region, such as paraspinal abscess, or lumbar region, such as psoas abscess, all palpable and is palpable in the iliac fossa. Now, for management, you need adequate drainage, debridement of the necrotic tissue, of course, management of the dead space, and anti-TB, and restoration of the blood supply. So here's a question as we reach the end of this lecture. Which step occurs after increased intramedullary in the progression of osteomyelitis? This is when we discuss the pathophysiology of the osteomyelitis. So it will be exudate extending into the bone cortex. Okay? Next question, which of the following is the risk factor for developing osteomyelitis? So it is C, sickle cell disease. Finally, we go to the last clinical lecture, is arthritis. Now for arthritis, there's barely anything I've added because generally most of it we did cover in the um pathology lectures, but just to mention the management here because we did not mention it there. We usually educate the patient on osteoarthritis. We educate the patient to improve the function of the a joint, um, so on. There is conservative management such as exercises to strengthen the muscles around the joint, and we advise them to avoid unnecessary stress, use a walking stick, weight loss, control pain by NSAIDs, painkillers, steroid injections, or for rheumatoid arthritis, other manifestations that show up other than the ones we mentioned above are kidney manifestations. These usually come for those who are like for those patients who are drug used. Okay, there's hematologic manifestations such as anemia, neutropenia, and so on. And there's eye manifestations. These are shown here in the images. So there's conjunctivitis sicca. We mentioned this. So it's the dry. There's episcleritis. So it's inflammation of the episclera. And scleritis. So sclera. There's also C1 to C2 subluxation. So it's shown here. And those C1, C2 vertebral bodies. Okay? Rheumatoid arthritis criteria. This is a criteria used by doctors in clinics to like upon patients so that they can grade them when it comes to rheumatoid arthritis. So first criteria is morning stiffness. We mentioned this before. Arthritis for 3 or more joint areas, asymmetric arthritis, rheumatoid nodules, and serum rheumatoid factors, along with radiographic changes. Okay? For psoriatic arthritis, I believe we did not mention it in the pathology lectures. Um, again, it's just because the like I went as the lectures showed exactly. So when the pathology lectures did not mention psoriatic arthritis and the clinical ones mentioned it, I exactly okay. This is just to avoid confusion. Psoriasis and psoriatic arthritis, it's the psoriatic arthritis is generally um arthritis or inflammation of the joint along with psoriasis. Okay? It usually shows in more than like in 2 to 4 joints. There's spinal involvement up to 40% of the cases. There's tenosynovitis and nephritis. There's dactylitis. Dactylitis are sausage digits. You can see them here. And arthritis mitulans. Yeah, these are all shown in this. Okay. There's also a score for psoriatic arthritis, and it's called the Caspar score. So use to score the patients to know how to treat them. Okay? Different categories you can see here and different points given for each category. Next one is pseudo-gout. We did mention gout in pathology or biochem actually, but we did not mention pseudo-gout. Pseudo-gout is just like from its name, it's fake because it has different features. First of all, it's not the same monosodium crystals. It's calcium pyrophosphate crystals and shows differently under the microscope. It's in the knees and wrists, like in opposite to gout, which is in the toes, and it shows chondrocalcinosis, which is calcification of the cartilage, and it's in men and women over age 60, increased risk in those with diabetes, renal failure, parathyroidism, low magnesium, hemochromatosis again. The treatment is you treat the primary disease. So if it was any of these it's mentioned above, and you give NSAIDs, colchicine again, and steroids. Okay? Pop. Which of the following is an appropriate management strategy for osteoarthritis? We just mentioned this. Okay, so it is a conservative therapy with muscle strengthening exercises. Now we are done with biochem, pathology, clinical. خلاص. For the final lecture, it's genetics. Um, just as a disclaimer, the genetics doctor that is teach from the one that we were taught from. So that's why I generally included everything that the lecture had, all the slides, because I did not know what to focus on, since I was not taught by that doctor. However, inshallah, it's like some of them are mentioned also from our previous lectures. Okay, so as an introduction, the musculoskeletal conditions um in genetics are the second most common reason for physician visits, okay? And they cause a major impact on quality of life, okay? There is bone and cartilage structural proteins, which are the collagens, and bone modeling depends on the osteoblasts and osteoclasts and everything here we mentioned before, just very brief introduction. The disorders are primary bone involvement, such as skeletal dysplasia, or bone involvement in syndromes such as paroxysmal paroxysmal disorders, and Vater association. Vater stands for these. So V for vertebral defects, A for anal atresia, T for tracheoesophageal fistula, um, with the esophageal, and R for renal dysplasia. Okay? Now the skeletal disorders classification are as seen here. First of all, the first classification is the traditional one. Okay? There is four entities under that. So first of all, there's dysostosis, which is localized defects in mesenchymal cell migration. And examples for that would be aplasia, supernumerary bones, premature suture closure, and rib fusion. Dysplasias would show genetic mutation, bone cartilage formation and growth, and includes osteodysplasias and chondrodysplasias, okay? Does not imply precancerous change, however. I'll go back to the dysplasias later on, okay? By the way, for the dystosis, here's a picture, okay? That was shown in the lecture. For the disruptions, it's secondary malformations due to skeletal causes, okay? And osteolysis is the normal development, however, shows later as bone resorption, okay? The second entity or the other classification is metabolic bone disorders, genetic metabolic conditions affecting skeleton, such as nucleopolysaccharidosis or Herder syndrome. Okay, these pictures were attached to the lecture, so of course I added them for quick. The key definitions that you need to know to complete this here are the following. Micromelia means an entire limb shortened, okay? Rhizomelia, proximal segment shortened, okay? So such like proximal, okay, no, distal. Mesomelia, the middle segment shortened, and acromelia is distal segment shortened. Periaxial and postaxial polydactyly are extra digits on the ulnar or fibular side, are postaxial and preaxial if they are located on the radial or tibial side. Okay. Now the brachycephaly and cephaly are other definitions that you need to know. Wormian bones are associated with osteosis imperfecta, cranial dysplasia, trisomy 21, and hypothyroidism. Okay. Here are other key definitions also. So brachydactyly is short fingers. Polydactyly is too many fingers. Syndactyly is two or more fingers that are fused together. Okay, such as this. This is a syndactyly. This is a polydactyly. And I don't think there's a brachydactyly here. Camptoly is contractures of fingers. Clinodactyly is inclined fingers, usually a fifth. This is the one. No, this I mean this one, clinodactyly. And Arachnodactyly is long spider-like fingers. Other key definitions that we were talking about above, but here are some pictures so we can get to know them better. Are scaphocephaly and brachycephaly. Scaphocephaly is the lateral flattening of the skull. Brachycephaly is the posterior shortening, as seen here. So lateral is here, and anterior posterior is here. Okay, this is the normal one in the middle. Wormian bones are small bones in the fontanelles. Okay, the posterior or the anterior fontanelles. Okay. Skeletal dysplasias overview. As we said, we're gonna come back to dysplasias. So basically, these are generalized abnormalities of the bone plus cartilage growth. The birth incidence is 1 in 5,000. And the range is mild short stature or it can range from mild short stature up until up to neonatal lethal cases. Okay. It's highly genetically heterogeneous, and the diagnosis identifies which bone region is affected. Okay. The anatomical regions of dysplasia is basically this is just the basic anatomy of the bone that we talked about above. Remember it? So it's the epiphysis, the epiphyseal plate, metaphysis, and diaphysis. Okay. In the epiphysis, there are area of secondary ossification, usually present at each end of the long bones, and the metacarpals and metatarsals one epiphysis. However, the irregular bones, such as carpal bones, each have a single ossification center. The neonatal features have limited ossification of epiphysis at birth. Only the proximal tibial epiphysis and distal femoral epiphysis are seen on neonatal X-ray. Okay? Clinically, the disorders of epiphyseal development often cause pain and osteoarthritic complications in childhood life. Here's normal, the hypoplastic, and the irregular. In the metaphysis, it's located immediately adjacent to the epiphysis, as we saw above, and it's growing area of the long bone. Okay, we talked about that before. Clinically, the conditions that are predominant, these are the conditions that predominantly affect metaphyseal development, such as achondroplasia, and often lead to short stature. Okay. In the diaphysis, it forms the central shaft of the bone, and it's enclosed by the periosteum. Clinically, its involvement may lead to bone deformity and fractures. Okay, which makes sense because it's in the middle. Now, we have another prefix, which is spondylo. Now, when we say spondylo, this indicates the involvement of the spinal column or the vertebrae. Okay, this may result in scoliosis. Scoliosis is the irregularity of the irregular alignment of the spinal column, or kyphosis. Kyphosis we mentioned above, which is the bending and the visual hump that you would see in the upper back, and short spine, of course. This is how it would look. This is scoliosis, okay, and this is how they would look bending down, okay. So scoliosis, kyphosis, again, lordosis. Lordosis is kyphosis is talking about the above part of the back, okay. This is just to like show the different like medical terms more. Okay. Here is the involvement, like, and the disease category. So basically, each disease has these like combination of these involvements. First of all, this and this. Okay. So these are the bones, and this is like how the vertebral body is. Okay. This is a vertebral body. So this is a normal bone, and this is a normal vertebral body. However, in epiphyseal dysplasia, there is B and D. So this is how the bone looks, this is how the vertebral body looks. Metaphyseal dysplasia, it's C and D. So epiphyseal and metaphyseal only concerns the long bones, not the vertebrae. However, in spondyloepiphyseal dysplasia because we see the word spondylo. Um, Spondylo. It means there's an involvement of the spinal column, which is the vertebra. So it's B and E. Okay. The spondylometaphyseal dysplasia is C and E, and the spondyloepimetaphyseal dysplasia is B, C, and E. All right. Um, the common skeletal dysplasias make up for 70% of the cases. So we have the achondroplasia, dysplasia, osteogenesis imperfecta, achondrogenesis. The first one, achondroplasia. This we did not go like that we did not cover this before. So it's basically an autosomal dominant disease or syndrome with an FGFR3 mutation, and it shows this disproportionate short limbs with bullet-shaped vertebra. Okay, on imaging. It has large skull vault and small foramen magnum. This all shows in this picture here. Okay. The pathophysiology is basically that the mutation FGFR3 regulates the chondrocyte proliferation. Okay. So when it's mutated, like when it's normal, proliferates chondrocytes normally, but when it's mutated, the causes failure of plate cartilage and impaired endochondral oscillation. The FGFR3 is primarily expressed in proliferating chondrocytes, and um, it's tightly regulated proliferation and transition to differentiation. Some of the FGFR3 is expressed in pre-hypertrophic chondrocytes, and the therapy is actually a new therapy. It's also retired. Okay, I've added pictures here, pictures, and this is how they look. Okay, this is what we like. It's the most common cause of dwarfism. Okay. Here are some other pictures showing the stature of the kids and autosomal dominant, okay? The second one is thanatophoric dysplasia. It's the most lethal neonatal dysplasia. Findings are short ribs and wide costochondral junction. This of course affects the heart and lungs. Severe spondyli and telephone receiver femurs, such as these, because they look like a telephone. Okay, so in this image, clover leaf skull, as shown here. So it looks like a clover leaf with 4 leaves. Okay, and in all cases, there's de novo FGFR3 mutation. So this mutation is super important to memorize. Okay, in these dysplasias. There are different ultrasounds showing here, but for the case of time, I'm not going to go through every single one. But and because it's also going to be most probably covered in the like in the OSP crash course, since it's radiology, but do go over them, okay? The osteogenesis imperfecta we did already mention um like a repetition. It's brittle bone disease, defect in type 1 collagen. There is fragile fractures, blue sclera, hearing loss because of the defect in collagen in the ears. Okay, and there are types from mild to severe, so on. And the treatment is bisphosphonates because it decreases bone resorption. Okay, here are some pictures. See the bending of the bones and so on. And here are the classifications of the incisions perfecta from like types and so on. This was in the lecture, so I just added it, but I generally do not know how high yield it is. Just know the like the gene defects, of course, and yeah, maybe just the types that are mentioned like here. Okay. Other skeletal dysplasias are Ilsban Creveld syndrome. It's known as chondro ectodermal dysplasia. It's autosomal recessive shows short limbs, narrow chest, polydactyly, nail and dental abnormalities, and 50% have congenital heart disease. Okay. Um, Shown in these pictures, polydactyly, um, and so on. Okay. There is also osteopetrosis, which is marble bone disease or osteosclerosis. The definition is cartilage forms. It's basically just that the genetic defects cause excessive bone mineralization, so the bone becomes heavy, thick, and dense, but brittle. Okay, and there are several types. So it can cause uh brain impairment and cranial nerves impairment, neuro uh, impairment leading to early infant death. Okay, pathophysiology is basically just that the increase of the number and cycle um in the moral spaces and the Haversian systems are reduced or obliterated, and the persistence of calcified cartilage that should have been resorbed. Also, the bone is largely woven and minimally remodeled into lamellar bone, which makes it more brittle. There's few osteoclasts, few active osteoblasts, a defect in bone resorption and remodeling. Okay, here are the clinical features. So there's bone fragility, marrow failure, cranial nerve compression, severe infantile burns. Here are some pictures showing that. This is called as the flask bone appearance. Can come as an OSP, something. Um, and this is like chondrodysplasia punctata. Uh, it's stippled calcifications in cartilage, especially epiphysis and airway cartilage, as shown here, the X-rays. Okay. Again, these will all be covered in the radiology, inshallah. That's why I'm going quickly over them, and also for the sake of time. Dysostosis multiplex, mucopolysaccharidosis. It has macrocephaly, thick skull vault, G-shaped cella, and hook-shaped vertebra. Okay? Again, cleidocranial dysplasia is another type. It is with wormian bones, and hypoplastic or absent clavicles, as shown here, and dental abnormalities. Okay, it's repeated. Uh, this is another entity, pycnodysostosis. And lastly, there's also collagen disorders. These are the mutations. Um, Shows facial dysplasia, ocular event, and includes Ehlers, Danlos, and Marfan syndrome, which we talked about. Okay, we're finally done. Here's the last pop quiz of this crash course. So a newborn presents with the congenital absence of rib and premature closure of cranial sutures. According to this lecture, the abnormalities are best classified as the following. So we did define those. It's this dysostosis. Okay. Last question. Which of the following pairs correctly match a skeletal dysplasia with its hallmark radiological or clinical feature? I'm gonna give you a minute to read those. Okay. It's B. Achondroplasia matched with pedicular distance in the lumbar spine. Okay. With that, we conclude the first part of the MSI crash course. I really, really hope it benefited you. And inshallah, if you have any questions, inshallah, I'll be available. And we'll quickly answer them. So please do send any questions that you have. Again, I hope that now MSI, like bones and joints, make more sense. I know MSI can sometimes be heavy or too much, but once you interlink the points and you connect the dots, inshallah, it will all be better. I wish you the best of luck in your exam and other exams. And yeah. Thank you so much. Please scan this QR code to send any feedback that you have. This will only help me um like deliver better pals in the future, inshallah. And thank you so much if you have stick to the end of this crash course. I really hope that you benefited. Oh, thank you very, very much.